It's been nice i gwrdd â pawb. Diolch am wneud yr amser i gael eich cyfarfod yma. Welcome everybody, welcome Kirsty, welcome Suzanne, welcome to everybody else on the board. This is the second of a series of public accountability meetings where I'm meeting with each health organisation executive board together with the Director General and the executive team at the Welsh Government, and it is our opportunity to have a discussion with you covering a range of areas, looking at finance, looking at access and service improvement, looking at how the board is getting services fit for the future, and looking at aspects of how the board is run. So that is the agenda that we have together today, as you will know. My suggestion is that rather than go around the table, which might take some time given the number of us here, that each person introduces themselves the first time they speak, so that we know who's speaking, obviously, but people watching from outside the meeting will wish to know that. The meeting is being live streamed, as we know, so the public will be watching, and there is an opportunity for people to speak in Welsh or English as you wish. Just to say, Kirsty, firstly, thank you to the board for the evidence pack, which has been provided. The agenda covers those four key areas. Obviously, in the evidence, there is a lot of assurance in relation to aspects of that. So we won't go over that territory in the discussion. We will look at the areas where we are seeking further assurance from the board. So we may not cover all of that agenda in equal levels of depth, reflecting the evidence given so far. And there are a number of points which I will be putting to the board which reflect themes which have come to me in correspondence from the public, so reflecting some of the priorities which the public have raised with me as well. Experience suggests that at the start of each of the four blocks, it's helpful for somebody from the board to set out, hopefully briefly, the board's position, and then we'll get into a discussion after that. I would ask those doing that to try and limit their contributions to about 4 minutes, so that we have enough time to be able to have a more detailed discussion about some of the elements which will come up, and ask as well for contributions to be tethered really to actions which the board is taking or plans to take, and the assessment which the board is making of whether they're succeeding or if there are challenges, what they are. Conscious, Kirsty, you're about 4 or 5 weeks into your tenure.
4 days.
There we go. Into your tenure, so this is coming early in your tenure. But I wonder if you, before we get into the agenda, whether you'd like to make some observations.
Well, diolch fawr, and Fro-Cardiff pawb. Good afternoon, everybody. I'm Kirsty Williams, and I'm the chair of Cardiff and Vale University Health Board. And as I just mentioned, this is day 44 in the role. As you can imagine, it has been a bit of a whirlwind, but I'm really grateful to everyone within the organisation and our partners, including colleagues here at Welsh Government, for the help and assistance that they have provided to help me settle in. In that last 44 days, alongside getting to know the executive members and my fellow independent members on the board, I have prioritised meeting our staff, our partners, and where possible, our patients. It's clear to me that our services and our staff are under a great deal of pressure, primarily because of the demands that we are placing upon them. But regardless of that, and regardless of what discipline they work in or where they work, in which setting they work, one thing unites them all, and that is a desire to provide the very best services for the population that they serve. And it literally shines out of them when I meet them. From a board perspective, I found a positive culture and good working relationships. But both Suzanne and I agree that there is more that we can do to build a truly integrated board, mindful of our individual roles and responsibilities, but where independent members and executives work together to deepen its strategic focus, where scrutiny is strengthened and constructive challenge ensures that our strategic plans and ministerial expectations are delivered. And all members of the board are really enthusiastic about taking that work forward. But Cabinet Secretary, there is much to be done. Whilst we've made good progress in some areas of performance, and I know that you speak very warmly about cataracts, for instance, other services like paediatric neurodevelopment assessments are too long. And we must underpin our performance by completing work that is already underway and crucially implementing that work, especially around a clinical services plan and a quality management system. Now, whilst we benchmark well in terms of our use of temporary workforce, our sickness rate is not where we need it to be. And we must do more to embed a value-based culture and effective clinical collaboration and engagement. And of course, financial sustainability. Whilst this year we will deliver our savings and financial plan, clearly that is a plan that has not been accepted by the Welsh Government, and we will not meet our statutory obligations. We must, as an organisation, chart a path to a sustainable financial position. And we must address these and other issues to enable us to give you and others the confidence and assurance that you're looking for, that will allow us to de-escalate from our current status of level 4 in all domains. Now, no doubt we're going to explore these areas in greater detail this afternoon, and I and my colleagues stand ready to answer your questions.
Great. Well, diolch yn fawr iawn. Thank you very much for setting out your reflections a few weeks into the role. Let's get underway with the discussion, and I think you've mentioned in your opening remarks there, Kirsty, the position in relation to the financial position for the board. So if you look at tertiary services as well, the Health Board controls the equivalent of 9% of the entire Welsh Government budget. So a very, very significant scale budget. The position is deteriorating and it's concerning. So I want to hear in this part of the agenda why that is happening and what the board is planning to do about that. So there's an opportunity for someone to set out the position before we get into a discussion.
Certainly, well, I'll ask Catherine to do that. Where's she gone? I'm here. Down there she is. I'll ask Catherine to do it.
Okay, so in terms of the position we're in, we were very pleased in 23-24 to hit our control total of 16.5 million. The following year, we set out to improve that position, but only marginally to 15.9. That was not the position we were able to achieve, and we had to revise our forecast. That came down to the 9.1 control total with an extra allocation. We had to revise that to 27.7 million because we were experiencing significant growth in demands, but also in pressure and inflationary costs. Those pressures and demands were in excess of our ability to make transactional savings and transformational savings. So we, as a health board, we've been able to deliver between 32 and 35 million pounds worth of savings a year, but we need to deliver more capacity releasing savings if we're going to deliver higher figures to keep up with our inflation, or we need to get downstream on our growth. So those are the two areas that we need to really focus on moving forward to make sure that our pressures don't continue to increase at the current rate, and also we can improve our financial position and get to a sustainable balance. The way we're doing that is that we're looking at, there's 3 pieces of strategic work we're doing this year. One is our clinical services plan, because we need to look at what are the services we need to deliver and how do we need to deliver them. We're also doing another piece of work around our networks and our clusters in terms of how do we manage workload and keep it away from the acute environment by dealing with more work in primary and community care. And the third piece of work is a piece of organisational redesign work that we're doing to work about our organisational structure, how we structure ourselves for success, and also how we make sure that we have a future operating model that allows the decision makers in our organisation at every level to make the right decisions for patient care and population health.
Okay, thank you. So look, in your evidence, there are a number of items that you describe as describing the in-year position deteriorating on page 3 of your evidence. But the reality of the position is you started the year with a deficit last year of 77 million, and you're currently planning about 56 million at the end of this year, which is, by any measure, a staggering increase in the level of the deficit, and it's happening very, very quickly. So I don't get a sense in the evidence of what accounts for that. There are some elements which relate to some aspects which get us to about 6 million difference. But you know, that's a huge level of deterioration in a very, very short period of time.
Yes, I agree. So in terms of in the evidence pack, the areas that we're showing there are actually the in-year delivery, the pressures on in-year delivery to the 56. They're not the reasons for the 56 million. So when we hit 27 million at the end of last year, we took non-recurrent actions to manage that position, and we also delivered non-recurrent savings in terms of some of our temporary pay spend, which we couldn't continue to deliver because we've gone on to be very successful in employing to almost all of our vacancies in the health board. So we've had a growth in workforce, and we've had growth across our non-pay areas at a level that we haven't been able to deliver recurrent and sustainable savings to solve to cover off and mitigate. That's what's driven the growth between 27 and 56.
So just in terms of that, just we'll get into some of the detail in a second, but the overall growth rate over the last 5 years is larger than all of the health boards, against a backdrop where the financial pressures have been clear for some time. So wondering how the board has applied that context to the choices it's been making around that level of workforce growth.
So I think we are seeing growth in CHC and prescribing.
But I'm just on the workforce element for now.
On the workforce element, we have been very successful in recruiting for all our posts. We have in the last few years had to increase our bed base and look at our establishment. We have got overall, I think we're at full establishment, and my colleagues can help me out with that. And obviously sickness means that we have a need for temporary staff, which we wouldn't need if we drove down the sickness rate. So getting to the source of those issues that drive the financial spend, because we want to be up to full or near full establishment so that we can have teams that drive quality care.
I understand that, but I'm trying to get a sense from the board of how you approach these decisions. So you have a deteriorating financial position and the largest growth in workforce of any health board in Wales, which is that you accept that position.
Can I ask Suzanne to?
Yes, of course, yes.
So I think the growth in our workforce has materialised since 2019. When I joined the health board in 2022, immediately post-pandemic, actually at that point, my sense of the team was they were experiencing very great difficulties with providing both high quality safe care. They were reflecting staff shortages and challenges right across the board. And clearly the configuration of the health board at the time was orientated towards the pandemic phase and stepping out of that. We were also spending, I think the first year I was here, Cabinet Secretary, spent very large amounts of money on temporary workforce to meet what was apparently a gap in the demand on us. And my sense of the approach at that point was to minimise the cost of temporary workforce and improve the quality of care and the coherency of the delivery of care. Continuity of care is a challenge for us. We then set about recruiting to full establishment, checking the establishments met the need using the various methodologies that we have, and setting the establishments to get to that point, with the ambition that we would drive out temporary work costs at that point. Some of our growth is associated with funded posts that come from Welsh Government, for example, things like the Genomics Partnership for Wales, the Advanced Therapies Programme, and other JCC funded growth. Huge piece of our growth in that timeframe was the development of the Major Trauma Centre, which brought a lot of success in recruitment on a regional footprint. Vascular surgery was another place where we looked to recruit regionally. And so I think that growth in workforce was an absolute ambition at that point for those reasons. What came forward at probably at the same time as the growth was happening was the cost of living crisis, the inflation that we were seeing across the board, whether that be in costs associated with delivery of services or with non-pay issues. And I think that is where our planning hadn't identified that crosshairs moment was going to land in the way that it did, and it started to drive an underlying deficit. Subsequently, I think we have talked at quite length about whether or not we should reorientate the substantive workforce and have more of a blended approach to substantive workforce with the overheads associated, to enable a proportion of temporary workforce that we would aim to have, say 95%, that would give you that blend and maybe balance some of the costs of having full substantive workforce. We have held a significant number of posts over the last 2 years. We've looked to voluntary early retirement to address some of that challenge. My colleague could give more details on that, but I think that might be the nub of the issue that has manifested over the subsequent years, alongside some of the inflationary pressures that Catherine has referred to.
Okay. I'll bring Jacqueline in a second on some of the points which you're looking at over the course of this year, but I'm trying to get a sense, really, of what the board's sense of its own agency is in relation to this, and the board's own analysis of the extent to which these are external pressures which the board can't do anything about, or here are some things which the board has as a set of choices which either we haven't made and should have made, and you've made some, I think, important points about planning there, or what your take is as a team.
I think we have agency, Cabinet Secretary. Clearly, I'm the accountable officer, and the board has autonomy. That these organisations have multiple audiences and accountabilities, and I think the board seeks to respond to all of those, but obviously to make the right decisions at the right moment to either address a forthcoming risk that we've identified, and or create agility in our decision-making process so that we can respond to risks that emerge maybe we're not unexpectedly. And so I think it's clear we set a plan. That plan was working right up until the year before last. We delivered our control total, and at that point we started to move beyond that position. And I find the challenge is often, and I've discussed this with the finance director in NHS Wales, is when we're on an annual cycle of planning, the ability to adjust the financial expenditure in year is difficult, because the things that you can do are largely related to constraints on workforce, or suspension of services in some way, which is always very challenging to do and to consider, because it has ramifications on the health and well-being of the population. You will understand that. And I think what we haven't done yet fully, as much as we would want to do, and what I'm sure you would wish us to be doing, is that forward planning, a strategic approach to addressing our sustainability challenges. And what we've been doing this year, and Catherine was referring to that, is articulating pieces of work, because a clinical services plan for an integrated health board of our scale, size and complexity is not a straightforward piece, and we need to attend to the work in the community, the work in the hospital, the specialist services that we provide, which obviously includes some of these areas of genomics, practice, advanced therapies, as well as the kind of way we work in a system. And those pieces of work are underway at the moment in parallel. I think our belief is, I feel that once we've got the products of that work, and we'll have a high level plan by the end of this financial year, that will then give us the component parts that we can start to share with Catherine and her colleagues to say, right, do the financial modelling on this model. What does that look like for forward sustainability, as well as meeting, both Healthier Wales intentions for the population's health and well-being, as well as our own strategic direction.
Okay, thank you, Jacqueline.
So I think one of the bits that I think we've spotted is how much your band 9s have gone up. So I think, if I'm right, is that about 100? I've got that.
No, so we've been doing some work around where the workforce profile has changed.
Yeah.
Yes.
Across Wales and individual organisations. So I think one of the reflections from a Cardiff and Vale perspective is above the average growth across Wales. That senior management leadership type cohort has grown significantly over 5 years, which I think is the spirit of your question.
It is, yeah.
Okay.
So I suppose the bit here is about you understanding the profile of what actually your staffing looks like compared to, we always use 2019 as a benchmark, everything's pre and post COVID. But where that's actually increased, and why there might be some, as you've talked about, trauma units, et cetera, that might have increased that. But it is, I think, as more substantial. So I'm just going to give you a list of things that I just wanted to explore. It's all on the same thing. And of course, you know, we walk around our wards and most people will tell us that they're overworked. There is something about how do we also work with our teams differently, and what your plan is about how we redesign with them their own workflows to reduce that feeling of pressure on there. Because as you know, the money's the money. So we have to do something different with our team. So what is your plan for your workforce to actually look at how we do things differently? And also how we use the headroom, and Sue might want to cover a bit more on this, because we've got quite a generous headroom in Wales comparatively, but it's sunk into budgets. And actually now we've got staff that are used to using that as their budget rather than actually using it as the flex for sickness, for specialing, etc. And the last question I want to understand is if myself or the Cabinet Secretary walked onto one of your wards and asked one of your ward sisters, tell me about your budget, tell me what it is, and tell me if you're overspent or underspent and why, whether they'd actually be able to do that.
Yeah.
Honestly, because
No, I think they're really good questions, Jacqueline. So I was listening and not writing them down. So maybe if I come back to you, Chair, and then we'll pick the list up.
so back what you've got that's grown and understanding that,
So far.
how you're using your headroom,
Yeah.
establishment, how you're redesigning how your workflows with your workforce, and actually has your people who've got budgets, do they understand them and have a grip of them?
I'll ask Suzanne to begin, and then Rachel, perhaps you pick up some of the.
So I think we do have an understanding of the workforce profile and the growth areas, and Rachel can give you some details on that. I think some of this growth has been in these technical, so biomedical scientists, healthcare scientists. Now, whether that accounts for band 9, we'll have to check. But there's been significant growth there and in practitioners. I think the headroom question you ask is one I've been asking, as Sue will know, for some time. What latitude do we have to adjust the headroom and or use it differently? And in a way, that was partly my sort of reflection of, is there a different way of fulfilling the establishment requirement and deploying colleagues within it in a different way? And that is certainly work that I've asked the Director of Nursing, he's not with us today, but Natasha, sorry, is with us and could respond to that. But I think that is an important part of the work that we need to do, whether that's reprofiling the work, making it good and satisfying for colleagues, and the workflows working efficiently. And of course, digitisation is a really big part of that, and we no doubt speak to that, as well as looking, are we the right skills for the role we've got? Are we overskilled or underskilled? And there's some opportunity there, I'm sure.
And is that work that's already underway? Is that not?
Yes, and that work around the establishment has been underway for several years, actually. I think the clarity, just to finish before I let someone else speak, the clarity around what proportion of our workforce expenditure is within our own budget and what is coming in through a whole range of different means of external funding, either associated with the delivery of tertiary services or hosted programmes, and there is a considerable number of those, is something we've been exploring, and we need to be really clear about what we're making decisions on and what is being agreed in the JCC or in Welsh Government as part of a big programme or wherever it is, or indeed clinical research. We've got quite a big drive in from HCRW and other areas of Welsh Government with good plans that we would like to participate in and are good for the people of Wales. But giving you a picture about that, I think, is really important.
Rachel, and then perhaps Natasha very briefly.
Yeah.
In the headroom.
I'm Rachel Goodman. I'm the Exec Director of People and Culture for Workforce. So nice to meet everybody. Yeah, we were posing those questions ourselves actually when we really get into the detail around all of our sort of roles and the growth. So we started off looking at the management level, probably at 8A above, and noticed that. But also we've grown in every particular area, but also noting the JCC. So we've just got that detail to really get into detail so we can go into the granular detail, and we actually take that to our People and Culture Committee. Also working with HCIW around the modelling and helping us look at the 95% and what could that look like going forward. So that is in train currently. I suppose the parts that Catherine has mentioned about our operating model is really important for workforce, because actually we can't reshape the workforce unless we know what the service we want to provide. So we've got to work really closely with the team around that.
Rachel, can I just interrupt?
Oh, sorry.
So you said at the start of what you said, these are some of the questions you've been asking yourself.
Yeah.
So what has that led to in terms of decisions, changes, benefits to the financial position?
Yeah, so I think if we look at the senior, as Jacqueline mentioned, the senior posts, that's the part that we're looking at with the potential restructure and the redesign of the organisation. So asking that question, has there been some creep? Is that our structure that we want? Is parts of it too lean? So again, it's looking at that standardisation of us as a structure, as an organisation to be successful. So we're getting into the detail, but it's really hard to say, let's just take these posts out, because actually we don't know what the model is that we need to go forward. But I believe that we'll be seeing some of this coming out at the end of this year, beginning of next year. So we'll be able to really look at that structure. Lastly, I'll just stop then because I'm not the clinical exec, but we've noticed that I've got a nursing background. Sometimes the ward sisters have a huge responsibility around finances, data. We've done some really great work around rostering and the importance of rostering and analysing their rosters with the headroom. And actually that's been really welcomed by the ward sisters to own it. I think our leadership and management programmes that we're doing in-house to complement HEIW, we're getting into that more management rather than leadership to help and support managers. But I don't think we're there for the financial side of ward sisters yet, in my view, my observation.
Natasha?
Yeah, thank you. So Natasha Goswell, Deputy Executive Nurse Director. You mentioned about headroom and uplift. Obviously, we're governed by the Staffing Act, which obviously dictates the establishment. We undertake a review every 6 months, which then goes through board, which looks at our headroom establishment, headroom and uplift for 25A and 25B wards. We know that some of our areas are at 24%, but that's our non-statutory requirements for some of our wards.
And Paul has got, I think, something he'd like to contribute as well, if that's okay.
Thank you, Paul Bossop, Chief Operating Officer. I think it might be able to help with a couple of things. So in terms of why we increased the numbers of band 9s, we did consciously upgrade the directors of nursing. They were 8Ds. We made 7 of them band 9s for parity across the trumpets. And we basically have band 9 ops directors running with their clinical board directors. Clinical boards that are as large as some of the DGHs in England. Some of these band 9s are holding on to £250 million budgets, etc. So that, I think 7 of those posts were because of the equality and the need to set clearly that there was a equal partnership. I think just in terms of your question, Jacqueline, about would the ward managers know, we've taken a really hard look at supernumerary status, and we've agreed with myself and Jason Roberts to free up the ward managers for at least 3 days a week supernumerary, so they can do the budget management, they can do the appraisal, they can manage the sickness, and not be dragged into running the wards on an operational basis. So that's something we've been doing for the last few months, and I think that is really starting to give us some benefits. So if you walked on the ward, would everybody know? I think I would like to think that there'd be a mixture, but more people would understand their budgets than perhaps would have done 6 months ago.
Okay, thank you. The bit about redesigning people's roles, because we've got what we've got, and actually the bit here will be reducing workforce, but I think we're sort of running out of time on some of this, and I think we'd like Howell to ask his question.
There's only one question we could. Howell Jones, Director of Finance, Welsh Government. So yeah, mindful of time, I guess, was reflected. We discussed a lot the diagnosis of why and how in this position. You said up front, Chair, of our needs and a route to path out, and obviously we agree in entirety. So what are your biggest opportunities as a board, and when will we see that route map?
Yes, so this is the challenge that I've given to executive colleagues since I came into the organisation, and I understand the pressure that everybody is under in this annual cycle, but we have to find the headroom and the bandwidth to think about the longer term, because if we stay where we are in this annual cycle, we're not going to make the progress that we need. So in discussion with Catherine, as Catherine alluded to, there are pieces of work that we feel actually are essential building blocks on which to look at the finances. We can't look at any part of the system on its own. So the clinical services plan is a crucial part of that. We expect to have a greater level of detail around that by the end of March. So my challenge to the executive team is, okay, we have to lift ourselves up a bit, look to the longer term. We're not going to be able to solve our deficit issues in one financial year. That would be, I think, would not be credible. And I'm absolutely of the firm belief that what we have to talk about is what we can do, rather than send you a work of fiction only to find out, plans on day one are easy to write to approve. But the truth leaks, isn't it? By month 6, you have to be able to deliver that plan. So, we want to be truthful, we want to be upfront and honest, but we do need to be able to articulate, not just to you, but to our own staff and our own organisation, what the future plans look like. So that's the challenge that I have laid down to the executive since I took over, and Catherine is up for that challenge. Well, yeah, but in her specific role.
So my supplementary to that is, should we outside of here get to the point where we agree that, when will we see that? When do you think you will begin to map yourself a pathway out of here?
So to your question, Hal, I think if you benchmark our performance, we know, for example, our length of stay in hospital length of stay is very long, much longer than it should be. That is clearly an opportunity. That is driving some of the demands we have on the rest of the system. Things like CHC, that is extraordinarily expensive. Mental health, CHC, extraordinarily expensive, and we have got growth variously in both those areas. So
Catherine's question was when.
No,
I'm conscious of
that was very helpful. Thank you, Chair. March 26 will be the high level plan, as I said.
So that's the clinical services plan, or is that the budget plan for getting out of deficit?
Sorry, so that is the clinical services plan.
So the Paul's question is about when are we going to get a map
Well,
back to where we are?
I would anticipate we would do that through the course of next year. Clearly, we're in annual planning now for next year, and we'll be doing our very best to respond to the challenge that will inevitably come. We need these products. I think it would be foolhardy for us to commit to you to do it any earlier than that, Cabinet Secretary, because we don't have the products we need to give you the credible answer. So we could give you a time horizon, but it wouldn't be a credible one, and it wouldn't be one that would fulfill. So I think that's what I would say.
Right, look, there's a lot more to go at here, but there's a lot of ground to cover elsewhere as well. So we'll move on at this point to the next item, but we will be coming back in a later part of the agenda to the clinical services plan. I do want to talk a bit more about the annual cycle and the planning assumptions as well. Suzanne, we'll come on to that. So the second part of the agenda is about what the Health Board is doing to improve access to care and improve service delivery, the performance of its services generally. So
Professor Steve Riley, who is an independent member, open brackets, university closed member, is going to lead off on this item for us.
Thank you.
So following the end of the COVID pandemic in early 22, the Health Board has been working to reset the operational performance, how it's viewed, and predominantly as the outcome of delivering high quality patient-centred care. And it's therefore everyone's business rather than this being targets to be achieved. There's also been a need to review the skills and capabilities that we've already discussed, the operational teams, how they transition from the firefighting mode, command and control responses required in the pandemic to a much more planned and forward-thinking approach, which is what the work that we're trying to do at the moment. We need to reset the expectations around the operational grip and control. That's been key, and examples of this include the improvement in the ambulance handover times from in excess of 4 hours down to 45 minutes, and to be able to directly link that to the improved patient experience, safety, and the outcomes that we see across the health board. Difficult choices have been made at the board level to ensure the capacity is available to be allocated to the most clinically urgent areas. In September 2022, only 40% of patients on the single cancer pathway started their treatment in 62 days due to the wait for diagnostics and theatre capacity. The Health Board hasn't delivered to the 75% standard as yet, but we have achieved 70% plus on occasion, and we're narrowing in on that clear trajectory to deliver the standard by 75% by March 2026. In 2024, the Shaping Our Future Excellence programme was launched in response to the emerging themes from patient safety incidents and nationally reportable incidents. The overarching aim of the programme is to eradicate the avoidable harm to patients, for example, by not exposing patients to the risk of healthcare acquired infections, avoiding deconditioning in hospital due to prolonged lengths of stay, and not exposing patients to unnecessary tests and examination. Alongside this, initiatives such as robust incident reporting, the WHO checklist, compliance, falls prevention, and harm reviews demonstrate progress in quality and safety. Patient experience remains central with enhanced complaint handling, inclusive engagement, and targeted service improvements, ensuring better access for all. These achievements reflect our ongoing drive to deliver safer, more responsive care for every patient.
Thanks, Steve. A couple specific questions, because so diagnostics. Getting your test is obviously the first step for people finding out what's wrong and what treatment they need, or the point at which they're told they have the reassurance that they don't need further treatment. So either way, it's really important that happens promptly. You have 14,000 more or less currently in excess of the target wait time, and that's about 30% of the entire Welsh position, which is obviously very significant. So very helpfully in the evidence pack which you've sent, you set out the steps which you're taking in endoscopy, NOUS, MRI, CT scan. So that's all helpfully set out. My take on what's in there, and it says very openly, and we know this, there's a lot of progress being made through insourcing and outsourcing, and I understand why that is, and it's what you will need to do to get to an improved position. But it's very open as well that there are, in the longer term, gaps in capacity to be able to address those on a sustainable basis. So what I'd like to hear from the board is what your plan is to address that, so that you're not in a position where you have to be doing the work that you're obviously having to do now. We support it around insourcing and outsourcing, but that is not a sustainable position. So what's the plan for that?
Yes, no, thank you, Cabinet Secretary. So you're absolutely right. So once we cleared the backlog, and we are very confident that by March we won't have anybody waiting over 8 weeks for a diagnostic. We're about 17 sessions. If I talk about endoscopy, we're about 17 sessions a week short currently of the capacity that we need. But that's where the Lantrison Health Park comes in for us. So the sustainable solution for endoscopy is to be part of the Lantrison Health Park, and that's what's in the business case, and that's what we're signing up to do. So we are confident that there is a sustainable solution. We're going to have to work through what we do next year in terms of the bridging, but with a clear the backlog, we know the size of the gap currently, and we signed up to Lantrison Health Park to deliver that on a recurrent basis.
That's very helpful. So just for my understanding, so the gap which you've been very open about in your evidence, is that one which you will continue to be able to fill through outsourcing and insourcing arrangements until Lantrison comes on stream, or do you think there's going to be a dip?
Well, we need to work out how we're going to pay for those 17 sessions recurrently, but that is the recurrent gap as we see it. So yes, we need a plan next year, which we'll need to work with colleagues about how we resource that. But we wouldn't want it to dip. That clearly is a risk, but we've got time now to work through what do we do from the 1st of April.
So we're currently in the planning cycle at the moment, and obviously these are considerations that the board will have to engage with and make decisions upon.
Thank you. So the other question relates to the 104-week rates. So again, in the evidence, you've been very, it's very clear that what you're saying is, as of today, you think there's a challenge in relation to spines at a 2-year wait point. We are providing some expert input to work with the board about how that can be addressed. I guess my challenge really to the board is this: accepting as we were, we all will, this is a health board with 9% of the Welsh Government's budget at its under its control. Is the board's position that there is no solution to the spines problem, or if not, what is the problem? What is the issue which has led to it not being solved today?
Okay, so first of all, it is absolutely not the position that we cannot solve the spines problem. Clearly, those individuals, because whilst there are numbers in the pack before us all today, those are individual patients that need a service. And Paul and I have discussed about when those patients will be seen. Because if we don't meet the 104 weeks, we can't leave them languishing. When are they going to get a service, and how are we going to plan for that? So Paul is working, as you said, to try to identify solutions and support so that those patients at the moment, Paul tells me that we will be able to get to those patients in Q1 of next year. But before we then to identify what the solutions are for that cohort. Yeah.
No, thank you, Cabinet Secretary. So just, if you could just indulge me for a second, just to set some context. So we've come from a position in April 2022 where we had over 9,000 patients waiting over 104 weeks, of which 955 were waiting over 3 years. As of today, we're down to 981 over 2 years, and 18 patients waiting over 3 years. So we've absolutely got the intention to do this. The issue with spinal isn't about money per se, it's about the specialist capacity to do the work. We've got about 8 spinal surgeons. I think Swansea's got a similar number. We are working on a regional solution now with colleagues from Cyfarfod and AB about what is a sustainable solution for spinal surgery in South Wales. So we're not looking at it just as a Cardiff and Vale issue. We are absolutely committed to having these patients treated. We absolutely would want to have 0 patients waiting. But if we end up with a small number of spinal patients with plans to treat those patients next year, that's currently where we're at. If we can do it quicker, we will, but it's about the actual capacity to do the work, the specialists to actually do the work. That's the more the rate limiting step.
So just unpack that a little bit. So what is your analysis of the challenge which you are trying to solve?
And my analysis is that we will get into a current position, but not by March next year.
So that's helpful to the time frame, but the problem that you're trying to solve is what?
The problem we're trying to solve, is to have enough recurrent capacity to deliver complex spinal work. We believe that we've got that, but not in the timescale that's set out. So we can't get there by March, but we would expect to get there over the course of the next year. But we do need to work with our other partners so that we've all got an equal kind of waiting list, a shared waiting list, and a shared way of doing things.
Yes, and that's worked well in other areas, so that's positive, clearly. So,
Yeah.
so is what you are saying that this is about a new way of working that the health board needs to require from clinicians, or are you saying there's a capacity issue in terms of the numbers required to deliver the service?
So I think there's a bit of both. So we have already seen new ways of working with the way in which the spinal network have set out how to see outpatients, how outpatients are to be seen, diagnostics. We believe there is recurrent capacity, but it's just going to take longer to clear the backlog than March. So we will get there.
Okay.
Yeah, thank you, Carlos. Thanks, Paul. And I think, it is worth highlighting the progress that you've made in terms of, the removal of the long waits. I suppose where I'm at is twofold, really. There's a question of pace and approach. So you still, I think it was Nigel not that you sat here with today. So ultimately, our sort of second biggest health board in Wales has the second highest number of 2-year waits and has had that for quite a long period of time. There seems to be quite significant opportunity in terms of modernisation of your services, whether that's through the clinical validation approach, the clinical variability, utilisation of your resources. And I suppose it's taken us, we said sort of post-pandemic, I always think it's like you, Suzanne, it's 2022 really, and on. And we're still sat here 3 years down the line, and we haven't recovered from that period of time. Now, that's true across Wales. We've provided you with outpatient resources to bring the total waiting list number down, and resources from a diagnostic perspective. I'm keen to understand what you're doing from a transition and transformation perspective in terms of your service to make it more accessible for patients, to bring those waits down sustainably, because we can't get into a position where we keep providing both financial and input solutions on a yearly basis. So where are you on that journey, I suppose, in terms of that? Because spines is one of them, but it's a very small part of the overall issue.
No, I think that's fair now. I mean, when you say we are still here, we have reduced the number of patients waiting massively, 9,000 to 900, and by the end of the year it will be less than 400. But I take the challenge. How we're going to close some of that gap is with the enabling actions. So, you know, we've already we're green on a number, but the next areas of focus for us, the ones we're amber, are really around theatre utilisation, and really optimising the high volume, low complexity lists at the Landdoc. And again, you've supported us with being able to set up the surgical hub there. We've already got the CAVOC, so the Cardiff and Vale Orthopaedic Centre there, ring fence protected area. And so getting full joints on the list is our next ambition. And we talked about the cataracts as well. So there's a lot to go for in theatre productivity. I couldn't sit here and say that by delivering on all of the enabling actions, that's going to completely close the gap, but we'll be better placed to see what the residual gap is. We know that in some specialties, it's a backlog issue. You know, but in other specialties, so general surgery, some gynecology, there's a recurrent capacity gap. We just need to be clear how much of the enabling actions will help us close that. But you know, you can see our intent. We've done it with cataracts. We are moving forward. SOS and PIFU, I know that's outpatients, but we put 4,000 patients on a PIFU pathway in September. That's the most we've done to date. That will create capacity to see patients more quickly. So don't underestimate the challenge. And we are embracing enabling actions, and we are grateful for the support. You've given us a lot of support, Nick, you and Jeremy and the team. But you know, and we have made good progress. But we started off with quite a high level of patients, and maybe it's taken some time to get there, but we're nearly there.
Yeah. Because I should just say this is an example of those areas where there is a lot of good work which is happening, which is not coming to this discussion because we're satisfied with the progress in those areas. You know, I will acknowledge the reduction that you're talking about, Paul.
It's only natural in a meeting of this kind that we focus on deficits. But I just want to make clear, you know, every day amazing things happen at Cardiff and Vale University Health Board. People delivering great service every single day. So I think we'd all acknowledge of that. There's still more to do, but I just want to get it on the record. That amazing things do happen every day.
Absolutely agree with that. Can I just ask on this area? So I was going to raise it into the next section about getting services ready for the future, but really you've raised it perfectly fairly in this context. Theatre utilisation, those enabling actions, the high volume low complexity, although excluding cataracts, where actually the progress is fantastic, isn't it? So and the day surgery rates as well. What's your view as board about the contribution those changes can make, both to performance overall, but also to down to the point you were making earlier about, you know, when there's an annual planning cycle, there's a financial, you know, it's sometimes challenging to make adjustments immediately. So these are things which ought to have multi-annual benefit if you can get them to the right place quickly. So what's your analysis of the board?
No, well, if I can make it out here. So I'd agree. I think the efficiency and productivity opportunity is huge. But it's a combination of many factors. It is clinical practice, culture, history, legacy, infrastructure, motivation, engagement, and all of these things need supporting and attending to virtually simultaneously to get the maximum benefit. Now, if I take the Lancaster and Howe Park Phase 2 business case around orthopaedics, which you know, Cabinet Secretary I'm leading as the Chief Executive Lead, I've had fantastic clinical engagement and support with that. And what we've sought to do is understand where there is opportunities to standardise in advance of moving into Lancaster, because that brings efficiency today, potentially, in advance of the clear opportunity that new facility creates. So we've done lots of work around that, looking at practice across the region and looking for those opportunities to share good practice. The anaesthetists have come together and done some fantastic work around pre-assessment and intraoperative pain management and so on. Some really good work, which, you know, actually has brought the team closer together, I would say, and they work in a different way now. It's just that you do the work, you improve the work. I mean, it's quite straightforward, really. And then I think there is the kind of piece around what, as we calculate, you know, back to your point about planning, what does the financial outlook look like? Paul and I and Catherine often have discussions about how much efficiency can we assume on that baseline position, and how we're going to monitor the delivery of that efficiency, because that will give us a number at the end, whether that's the level of activity we can anticipate delivering or the cost of that activity. And that's absolutely the work that's been done through the land trust and business case. And actually that, I suspect that has matured across the region, our understanding, because we don't have a shared understanding of what those baselines are, or what the assumptions will be for the future.
Do you mean between health boards or within?
Health boards, because we've kind of done it ourselves,
Yeah.
and now we're absolutely having to say, well, is your efficiency going to be as good as mine when it gets to the end? Because ultimately here in delivery here, we need to get to that standardised position. And I think that's been a good conversation. It's been a helpful conversation and helps us understand what those remaining opportunities look like. And of course, this is just in one specialty. We deliver beyond 200 specialties of intervention. The only other thing I wanted to say about planned care, which I think is important, is the preventative demand mitigation work, which really speaks to the strategic approach. We've really got to help members of the public, our citizens, those we serve, avoid the ill health and injury that comes where it is possible to prevent it. And we have got screening programs, we have got weight management programs. These are the sorts of things we can target more effectively, I think, to ensure that where we can activate a patient, we can work with them and they want to work with us, and lots of them do. I was at a fantastic event recently around the cancer prehab to rehab programme. Absolutely fantastic work, actually across South Wales, and some really powerful patient stories around the difference that had made to them in either their preparation for their cancer treatment or an altered pathway as a response to the work that was done in advance of that procedure having to happen. So I think there's lots of opportunity there. So we can mitigate the demand as well as respond to it.
And then you've seen some of that going, because we wouldn't have had much of an opportunity to talk about the relationship with primary care in today's discussion.
Yeah.
So what is the health board doing in terms of making sure that primary care part of the service is able to help manage that demand more effectively? What are you doing in that space?
Like you this morning, Cabinet Secretary, I was at the GP Practice Managers conference, and I spoke not long after you very much about how we support primary and community care to lean into some of this opportunity. And they're already doing it. They need support and resourcing, and some of that will need to come out of our hospital and secondary care infrastructure through efficiency, through new ways of working. I felt they were very much up for it, and we need to be part of the team, but everybody needs to be clear what that overarching strategy is, which is set out in our Shaping Our Future Wellbeing. That is about, you know, a shift away from illness to health and wellbeing, a shift from digital to analog, not a shift that way, the other way.
But
Taking us backwards, but and I think the whole system, we need to work with the whole system so that everybody understands what their part in the plan is, and that is absolutely the work that we will be doing through our integrated community care system, our acute model, and so on. And that's why those pieces need to come together, add up to a numeric position.
So just to draw a couple of these things together, because some of these themes are, you know, common themes. Okay, so the financial position, and we've had conversations with all health boards about what, you know, how to quantify current spend on primary care and preventative work, and what that looks like, you know, in terms of increasing the contribution each health board is making to that part of the NHS activity in years ahead. And there's a transformation programme which the CMO is leading with chief execs in that space. How will you approach that, though, if you've got the financial challenge that you've outlined, I'm saying to you, well, I want you to spend less money on secondary care and more on primary care. What are you gonna, what's the board's awareness of that challenge at the moment and how we'll get to grips with it?
So I think the board is aware of the challenge. Perhaps even more importantly than that, there is a consensus around, and indeed a frustration that hasn't happened, to date. So one of the questions that I'm considering alongside the vice chair, who gives us apologies today, and of course has a kind of responsibility in the regs around primary care, is how can we get greater focus on primary care within the operation of the board? Because understandably, the board spends, from what I've seen so far, and reading some of the papers, lots and lots and lots of time talking about the very issues that you've been exploring today and not then really focusing in. Now, part of that is about, I think, coming new to it, and forgive me, I haven't discussed this with these guys, so I'm going to go out on a limb now. Because of the organisational structure that we've got very much people working in silos. Yeah. So our primary and community care is in their own clinical board over here, very much divorced from operations that are going on in other places. We've got to, as part of our organisational work, break down those individual silos. So actually, we don't think about individual specialties. We think about the journey of a patient through a system. So actually, it is your business in the hospital to worry about what's going on in primary care. So part of the organisational work that is going on, I think, will help us get to that position. But as chair of the board, we've got to find ways of actually getting greater exposure to what is going on in primary care and what the opportunities are. And I guess if I can be super cheeky, the challenge back is, one of the things that would really help us do that, as you said, is setting that expectation and holding us to account for that. Because then if you're holding me as the chair of the board accountable for those plans, then obviously I can hold my executive colleagues to account for the implementation of those plans. So that's one of the ways in which I think you could help me as the chair do that.
We're definitely happy to help you in that respect.
Very good.
So we absolutely recognise that. And as Suzanne has heard me say many times before, what I would like to see are health boards doing the knitting without, and I mean that by performance, money, quality, your people, without us having to intervene so much, because we can see that there's an improving trajectory. Yes. And actually, when we set the planning guidance, as we'll start doing with you over the course of this next month, begin to look more towards the agenda that's in the community and the prevention agenda than actually the bits that actually we get. I mean, we have to keep going with the all the stuff we've just said, because if we don't, we'll never have the ability to do the bits that we should be doing. And health boards are absolutely set up to be able to do all of this. And you're right, I don't think we've seen many of them, actually, many of you take the opportunity to do that in the way that I think we would like, or you would like, actually. So we will start, as we work through the planning guidance, thinking about how do we do this differently. Mm-hmm. But that does rely on you all actually getting the knitting done across, getting good access to patients, keeping them safe, ensuring your staff have the right tools to do the job and are happy. And that, what's the last one I've messed out? Quality procurement money. All of those four things, because actually then we have more ability to do the thing we should be doing. So watch this space.
And you bring in the deputy medical officer, and then we're going to move on to the next section, Kirsty, which you've led us towards.
So James Calvert, Chief Medical Officer. So I completely endorse your approach with primary care, but if you wouldn't mind, I want to cycle back to two areas that you've mentioned where you mentioned things I'd like to pick out. One of them is around single cancer pathways, and one is around surgical involvement with the work that you've been discussing for Langtreston Health Park. So first of all, orthopedics, you gave really good examples of anaesthetists working together. Do you have examples of the orthopedic surgeons working together in the same way? Because at the moment, there is a resistance to narrowing down to 2 or 3 prostheses per site. And I'm very concerned by the cost it will drive into the system unless that concordance is reached, and the safety issue of having 3 different surgical teams using 3 different bits of kit. So how are you addressing that?
I think we're pretty clear, James, that by the time we get to Land Trust Health Park, we will have agreed the processes for use.
Yeah, and to
You know, as I said, I've got good, I've got purposely, I don't have a Cardiff and Vale clinician working alongside. I mean, I do have Cardiff and Vale clinicians working alongside me on this, but the lead for the region is an Iron Bevan clinician with whom you'll be familiar. And I think he and I and the national clinical lead for orthopaedics are pretty clear. But of course, we don't want to impose that on our colleagues. We want to work through it with them.
Yeah.
But ultimately, we will have to come to a place where there is a clear menu of prosthetics that are available for use, and where there are escalations needed, and we were not planning to do revision of complex arthroplasty surgery at
yes.
Lanchester, and that the vast majority of that work will continue to happen at CABAC at UHL. But the same applies there, really. I mean, the same applies across the board. We have to agree, not necessarily for the financial benefits, although there will be financial benefits, but we have to agree what is the best quality intervention we can make and standardise. That is my view. But I really, it is not a good place when we have to get into mandating these things with our clinical colleagues at all. And we're experiencing some of that response right now. We haven't really mandated an awful lot, but I think there is absolutely something about how do we work together.
Yes, and I'm very happy to support you with that. It will be a safety risk to patients unless that is resolved. And I would expect the energy for that to come from the clinicians. But if it doesn't, we may need to draw a line. It's been done in NHS England, and I get too much special case pleading in Wales, so I'm not to accept it.
I appreciate your support on that.
And then single cancer pathway very quickly at the time.
Yes.
Okay, so you are to be congratulated on your single cancer pathway performance. It's amongst the best in Wales, and it's been consistent over the last year. Are you comfortable you're going to be able to sustain that? Because I see that the number of patients waiting over 62 days has tripled from 130 in August 24 to 350 in August 25. And you're carrying 27-week bronchoscopy waits, 35-week sigmoidoscopy waits. Are you going to be able to sustain the really good picture you've got?
Yeah, no, thank you. So I will answer that question briefly, but I do want to give context. So 38% increase in referrals to single cancer pathway in the last 3 years.
Yeah.
Conversion rate static at 15%. So we are treating more patients every month with a diagnosis of cancer. That's gone up from 190 a month in 2022 to 250 a month. So 60 more patients a month are getting treated with cancer. So we are running really hard to stand still.
Yeah.
If we hadn't had that growth, we'd have delivered a 75% standard by now. Those diagnostic weights you quoted won't be for cancer. They are the 8-week problem that we touched upon earlier on. We are really clear that the diagnostic pathway needs to be 2 weeks for those modalities. We are confident that we're going to be able to deliver. The reason we've got that increase in the backlog is in 3 specialties: dermatology, 2 new consultants starting in January; urology, changes to the front of the pathway now from September; and lower GI, which has been a bit of endoscopy and a bit of theatres. So we will be at 75% by the end of March because we've made changes to the front end of the pathway. The reasons why patients don't get treated within 62 days is not because of theatre time, it's because we don't get the diagnostics and the outpatients done in a more timely way. So that's where all the focus is going. But yeah, I think we've done well to stand still, but we want to deliver that standard because it's important for patients.
That's really good to hear. Thank you very much for that, Paul. We're going to move on to the next agenda block, which is about what the board is doing to get services ready for the future. So who comes in and help you this?
Dr. Leon Thomas, who is one of our independent members and chairs performance committee, but Leon is going to do it. I'm going to be addressing us in the work.
Okay.
Yeah, I'll pause a second for the
I'll just talk away 1, 2, 3, 1, 2, 3, 1, 2, 3. Yes, I need to come here and okay. Yes, we have 1, 2.
Yeah.
Diolch yn fawr, gwrando a bawb. Na i ddechrau wrth ddweud ein bod yn fwrdd sy'n uchelgeisiol at gyfer y dyfodol. Nid yn unig o ran ansawdd y gofod sy'n ei ddarparu, ond hefyd o ran lleihau anghydraddoldebau a gwella iechyd y boblogaeth yr ydym yn gwasanaethu. Rydym yn sefydliad angor sy'n ystyriol o'n cymuned a'n hynggylchedd, ac yn sgil hynny, rydym wedi bod yn creu cyfleoedd cyflogaeth i grwpio bregus ac wedi bod wrth i'r lleihau ein hôl troed cadfan. Mae'n strategaeth llunioed presiant y dyfodol, neu shaping a future well-being, wedi deilwro at yr egwyddorion hynny. Mae 2 o'r 4 amcan strategol yn ymwneud â cyflawni yn y mannau iawn a gweithredu dros y dyfodol. Mae'n strategaeth gyfan wedi gosod yn hyd-destun deddf llesiant genedlaethol dyfodol. Mae pob portffolio yn cael ei arwain gan arweinydd gweithredol, gyda chymorth cydweithwyr o bob rhan o'r sefydliad. Adroddir ar gynnydd y gwaith i'r is-gweithgorau priodol a'r bwrdd i sicrhau yswiriant. Fodd bynnag, nid yw ein gwaith cynllunio na'n cyflawniadau mor gryf ag y byddwn ni'n dymuno. Dyn ni'n cydnabod nad yw ein strwythur sefydliadol na'n model gweithredu bellach na fel sy'n alluogi llwyddiant. Rydym wedi sicrhau arbenigedd a'r dylunio sefydliadol, mae'r gwaith yma wedi dechrau, ac rydym yn disgwyl gweithredu newid yn gynnar y flwyddyn nesaf. Mae'n pobl wrth galon y sefydliad ac felly y newid hwn. Y bwriad yw cynyddu ei gallu a'i cyfleoedd i gyflawni ei potensial. Mae'r amgylchedd y maent yn gweithio yno yn un o newid cyflym, yn un o bwysau, ac yn un o ddisgwyliadau uchel wrth i'n cymunedau dyfu a heneiddio. Serth hynny, rydym yn parhau i fod yn uchelgeisiol ac yn croesawu arloesau a newid. Mae hyn yn hyd-byn a'n hamcan strategol i weithredu dros y dyfodol. Mae iechyd y boblogaeth a gofal sylfaenol a chymunedol yn elfen i ddatblygu ar gyfer y dyfodol. Trwy symud ein ffocws o salw i lesiant, o driniaeth i adar, ac o strytau gydrefi, byddwn yn creu system sy'n gynaladwy, teg, ac yn barod ar gyfer cenedlaethol y dyfodol. Mae gwella ansawdd y llywodraethiant yn ganolog i waith y bwrdd. Rydym yn mewnoso'r system reoli ansawdd gyda simiau pwrpasol yn arwain rhaglenni blaenoriaeth gwella a newid ar draws teatre, cardioleg, diabetes a chordio clinigol. Mae'r gallu sefydliadol ar gyfer newid wrth i'n datblygu drwy bentora, hyfforddiant ac academïau arloesol, mwyn cyflawni buddion mesuriadwy mewn effeithlonrwydd, profiad a chanlyniadau cleifion ac yn ogystal chynaladwyedd. Rhaid diogel fod yn rhagorol, teg, amserol, diogel a bosibiriol. Mae hyn yn cael ei amlygu gan cynllun iechyd menywod gen Cymru, ble bydd lleisiau cleifion clinigwyr a phartneriaid y trydydd sector yn lliwio dyluniad gwasanaethau. Hefyd, wrth draws newid gwasanaethau mamolaeth a newid anedig. Mae'r bwrdd wedi cryfhau llywodraethu, gwella staffio a gwella diogelwch yn y maes yma. Mae'r llwyddiannau'n cynnwys lleihau y nifer o ganlyniadau anffafriol, sef adverse outcomes, gwella gwerthwch tîm a cychwyn gwaith cydgynhyrchu drwy partneriaeth lleisiau mamolaeth a newid anedig. Mae gwasanaethau iechyd meddwl yn cael ei haildynio mewn partneriaeth ag arbenigwyr clinigol allanol, gyda ffocws ar modelau gofal integredig, hygyrchedd gwell a ddulliau gwella ansawdd parhaus. Mae'r gwaith o ddatblygu gweithlu yn sain yr ymdrechion i greu darpariaeth iechyd meddwl diogel, effeithiol a posturiol. Mae'n 3 blaenoriaeth o ran y gwaith sy'n ymwneud â iechyd y boblogaeth, sef cynyddu cyfraddau brechu, atal gordewdra a lleihau cyfraddau smygu. Mae dull system gyfan y bwrdd yn manteisio ar amgysylltiad cymunedol, gwaith cynllunio sy'n deliedig ar ddata, a chydweithrediad traws-sector i ben yr afael ag anghydraddoldebau iechyd ac i arwyddio llesiant. Byddwn yn datblygu fod y system gofal gymunedol integredig drwy'r gefnogaeth eang gan ein harweinwyr uwch, bydd y raglen trawsnewid cymunedol genedlaethol drwy ddylunio, sef y National Community by Design Transformation Programme, yn cefnogi hyn. Mae'n gwasanaeth diogel yn y cartref, Safe at Home Service, yn enghraifft o'r newid hwn, sef gwasanaeth ymateb cyflym am lesiantaeth yn y gymuned gyda'r gofal integredig i'r cartref, a mwyn ysgoi bod y claf yn gofal mewn ysbyty, ac felly yn cefnogi'r unigolyn i aros yn iach ac yn annibynnol. Mae'n trawsnewid digidol yn sylfaenol. Mae'r raglen sylfaenu digidol yn cynnig cynllun ar gyfer gwella iddfedrwydd systemau, effeithlonrwydd a profiad cleifion. Yn ddiweddar, bu gweithgareddau megis dull sgan for safety mewn cardioleg a uned aros byr cyfredegol, dull mesur canlyniadau a droddir gan gleifion, sef triage yn yr adran brys, a cheisiadau radioleg wedi ddigiteiddio. Mae sawl system genedlaethol hefyd yn gweithredu bellach, sef system ymwelaeth digidol newydd, system gofal llygad digidol ac cofnod gofal nyrsio Cymru. Mae gwaith ar y gweill i gyflwyno system radioleg newydd, FRIS, a system labordy LIMS 2 yn mis Chwefror 2026, ac mae'r system ragnodi electronig a gweinyddu Meddyginiaethau yn cael ei ddefnyddio mewn hanner yng Ngwrdd gyda'r gwaith i ystynu hyn yn cynyddu. Mae ystad a'n seilwaith yn her ar gyfer dyfodol. Mae angen i ddatblygu cynllun gydlynol. Mae'r cynllun gwreiddiol wedi esblygu o adeiladu ysbyty, tuag at lunio'r llwybrau clinigol yn lle, fel ein nisgwyl eisoes. Llwybrau a fydd yn cefnogi'r modelau gofal sy'n dod i'r amlwg a sy'n wedi galluogi dechnegol ac yn digidol. Bydd gwasanaeth acute a phrydyddol yn galw am ystad newydd. Mae cysyniad cynnar ar gyfer adeilad newydd gwasanaethau acute phrydyddol a'r safle'r mynydd fechan mewn ymgynghoriad a chyfarwyddwyr y byrdau clinigol ar hyn o bryd, ac mae wedi cael ymateb da. Edrych yn ymlaen at rannu hyn gyda chi yn y dyfodol.
Diolch yn fawr. There are two areas I'd like to be able to address as Chief Nursing Officer in relation to the Women's Health Plan, but I just wanted firstly, we touched on this a little bit already, in relation to the clinical services strategy and the dependence on so much of this on that. And I'm conscious as well that the Health Board has received a letter recently from some senior clinicians, and in that letter, I've also seen the response from the Health Board. In that letter, they express a concern, which I know that you, I think, challenge, or what I won't put words into your mouth, you can tell me what you think, but a concern that clinical input isn't always taken on some key decisions. And I wanted to hear from the board how you will make sure that in designing the clinical services plan, that is clinically led for reasons which we would all understand. I don't want to put words into your mouth about the letter, so there's an opportunity for you, Kirsty, to set that record straight.
Well, thank you very much, Cabinet Secretary. First of all, I just want to say that I regard, and I know my colleagues on this table regard, that strong clinical engagement is an essential. It's an essential to delivering a safe, effective and compassionate care that you would expect. And I'm really grateful to the consultants for taking an early opportunity, should we put it that way, to raise their concerns with me and the time that they've taken to share their perspectives. I met with the chair of that group last week. I have to say it was a very warm and constructive meeting. He and I have agreed that we will work together to address those issues. You would have seen in the response from Suzanne to the group, because that's how they wanted the letter to be responded to, that we acknowledge that some of the systems that we currently have in place around clinical engagement, the communications, for instance, is not working for them in the way that they would like. And in our response, we have an open invitation to ask them, if what we're doing at the moment isn't working for you, then share with us what actually would make the difference. And we hope that we will have an early opportunity to sit down with them and work through these things together, because that's what we need to do. We need to be in the room working through these things together. With regards to, I understand some of their frustrations. I get it. When I first met Suzanne, before I formally took up the post, she spent a lot of that meeting talking to me about UHW. To be honest, I thought maybe she was exaggerating what she was telling me. I was a bit sceptical. And then I went to the Heath and I walked around. In fact, I was there this week walking through some of the departments. And I understand what our consultant colleagues are telling us in terms of the impact of that infrastructure on them. And it has not just an impact on their morale, but it's actually talks to the efficiency piece that we were talking about. We had a bit of a dip last month in some of our diagnostics because some of our kit fell down. Sometimes we can't do what we need to do because the roof, there's a storm warning tonight. I'll be keeping a very close eye on it in a way that I wouldn't perhaps 44 days ago. So I understand some of those concerns, and we are committed, as you saw in that letter, to doing what we can to work together. With regards to the clinical services plan, they will be, an absolute integral part of that. Our clinical boards are absolutely crucial, and their voice will be heard in that. It needs to be heard, and we've had very successful engagement with our public, because obviously our public has to be heard in that space as well. So we're committed to working in partnership together. Not only have I met with the chair of the SMC, met yesterday with the chair of our staff group, because of course, you know, we've got clinicians working lots of different specialities and lots of different roles within the organisation. Those voices need to inform that strategy as well. But I'm grateful to our consultant colleagues, and I believe they will. You know, we're not a million miles away. Where we're not getting it right, we want to get it right, and where we can work together to achieve those to achieve solutions, then we will.
Okay, thank you. Isabel.
Thank you very much. Isabel Oliver, Chief Medical Officer. So I think it's great to see all that engagement, but I think our expectation would be one of clinically led service improvement and transformation. So not just about engaging and consulting clinicians, but allowing them to lead that service improvement and transformation. So I think it would be useful to, you know, if not today, but find out in due course how they are going to be affecting that leadership in the development of the clinical services plan, and just more widely what work you are doing to address the issues that have been identified through those various reviews around culture and behaviours. I think we understand that physical infrastructure is can exacerbate issues, but it is not the root cause of those issues. So it's understanding better the progress that you are making. The evidence that you've submitted highlights a number of engagement activities, but is thinking more about the transformation needed to make sure that clinicians are able to feel part and be part of the change and transformation that the health board is going through and needs to go through. Thank you.
Perhaps I can turn to Richard, Deputy Medical Executive. David Flex sends his apologies. He should be in a recovery suite just now, having an operation today. Richard.
Yeah, diolch yn fawr. Richard Scone, Is-Gyfarwydd Ymedygol, and so Dr. Richard Scone, Deputy Medical Director. I think I would rather be here than in David's position at the moment, just about. But I think you're absolutely right. I've been in quite a privileged position of having sat with the senior leadership team and being in the meetings where those letters came out from. And
that is the recent exchange
with the SMSC.
Okay.
And I've been in touch with the SMSC, the Senior Medical Staff Committee Chair, since then. And the one thing that struck me about the meeting was that the aims and what we want to get out of it is the same on both sides. The consultants, and it was the acute hospital-based consultants mostly because it was in the hospital, do really want to take part in being involved in designing the plan. That doesn't mean we'll agree with all of them all of the time. I mean, in my department, we might have 3 consultants and then a couple of different opinions about them, but they certainly need to lead it and come to a consensus and work with us and patients to deliver that care. Going forward, there's a commitment in the response from the exec to work with them. And I'm hoping that we will be able to meet with the SMSC in the coming weeks to find out how consultants would rather be engaged with, to make sure that we can get the message across so that we can actually consult with them and form that clinical services plan going forward.
Okay. Well, did you want to add?
Yeah, no, thank you. So I think, look, absolutely, we recognise we haven't quite got this right. I think what has been, I don't know, a bit chastening is that I thought we tried quite hard on some of the clinical engagement. So lots of the things that we've done, clinical summits, have all been clinically led. So changes to the stroke pathway have been clinically led, changes to the acute medical model and reconfiguration of how the medical services have been clinically led. You know, the implementation of the Ockenden review and how we did the labour ward review, clinically led, but clearly not getting it right. So, you know, we do need to do more of that, but there are not darkened rooms that we sit and work out what we're going to do. Our clinical boards are led by clinical board directors who are part of the senior leadership team. You know, they are leading those clinical boards with support from the directors of ops and the directors of nursing. But clearly, it's not landing where it needs to land. But I just wanted to give some assurance that we really are up for the clinically led, how we lead the organisation. But there's more to do clearly.
Okay, so Isabel made an important point about culture. We're going to come back to that. I want to discuss that more fully in a moment, but James, and then I'll ask Sue.
So,
Women's Health Plan.
So actually, when I've been in meeting with your executive board, I think you are very collaborative. I've never heard anyone in your board who I don't think is collaborative. And that makes me concerned that your doctors seem to wait for permission rather than to spontaneously come forward and volunteer the solutions. And consultant doctors in particular are in a very privileged position. They all receive between a day and a half a week of protected time from management. And I would expect them to be beating down your door with ideas and not you having to go and consult with them. That is, for me, what clinical leadership looks like. So I don't think it'd be fair for me to hold you accountable on this, but, you know, how are you going to change the culture so that the direction of travel is not you consulting with the consultants, but the consultants doing what their job title says and providing you with the advice without being asked? Because I think you're very collaborative.
I really appreciate, James, you know, the recognition of that, but clearly you have that view. Left to right is perhaps of a different view of the world, and we need to work harder because it is got to be, you know, a foundation stone of how we take our CSP forward.
So what I think I'm saying is they need to recognise their responsibility within the system. I think you've acknowledged very openly your responsibility, but I think nothing that comes out in this letter makes me think that they acknowledge that they have equal responsibility to communicate effectively.
Thank you. Sue.
Thank you very much. Sue Tranker, Chief Nursing Officer. Chair, I was just wondering about the Women's Health Pathfinder. So a good statement made by Dr. Ryan around your ambition for more effective integrated models of care, but disappointing to see that you've probably lost an opportunity to transition or transform your women's health services. I'm a little worried about you being behind your timeline. You're amber rated as one of the only health boards, I think, or one of 2 health boards that are amber rated across Wales. So disappointing given you were first out of the starter blocks across Wales when you picked up the health plan. Your evidence pack also lacks adequate evidence to give me assurance or confidence that there's a grip on the delivery of the women's health plan. So I'm just wondering what oversight the board has and where's your, alongside your ambition, where are your plans that will shore up the delivery of the women's health hub in time for 1st of March is where we're at. So I don't know who's
Claire is going to address that.
Thank you. So good afternoon, everybody. My name's Claire Bynon. I'm the Director of Public Health. And thank you for the question, Sue. I do appreciate that. So we were rated amber in terms of the Women's Health Plan purely because the bid that we put in terms of the second bid was rejected, and we needed to rework the plan. So we've been working really rapidly behind the scenes to rework that plan. It will be going through our value benefits realisation group tomorrow, and it will be submitted on Monday if it gets through that internal process. We are really pleased that we have identified a sustainable solution because we understand that this is one-off funding. So we've been trying to make sure we've got a sustainable solution for this rather than something that we're going to have to come back and say it's either a cost pressure, which obviously with the finances we've just discussed is not an option, or to, you know, have come cap in hand to you. So we've been looking at sustainable solutions. We will have our first community hub, which will have a holistic focus on menopause. And that will be based in the Malfa hub. The aim is to provide that holistic service that will address and improve the quality of service around menopause, and will be available both for self-referral and also signposting from primary care. And we believe that that will sort of meet the needs of the Women's Health Plan, but also meet the needs of our local strategy as well, which is all about improving access to services, reducing health inequalities, and making sure when people do need services, that they're really high quality. So we've done a huge amount of background work before we've got to this point. So we've already done a rapid population scoping assessment, which identified some key issues, of which menopause was one. We've commissioned a health needs assessment based on the 3 priorities. So that's menstrual health, menopause and contraception. And we are engaging with our third sector to make sure that the patient voice is heard and is really central to our planning. We've also undertaken a waiting list review, and we have also undertaken a training needs assessment. So there's been a huge amount of work that's gone on behind the scenes. I hope that reassures you. Thank you.
It does, thank you. You've got a huge amount of work. Can I just ask us one follow-up to that? You've talked about your third sector and women's voices. You've got one of the most diverse populations across Wales. Have you ensured that you have captured the diverse voices within the, I suppose, within the third sector work that you've done?
Absolutely.
Okay, thank you. Thank you, Captain Secretary.
Okay, thank you. I want to move on now to the final of the 4 areas that we're looking to cover, which is how we strengthen how we run the NHS, and in the context of this discussion, how you're strengthening how you run the health board. So, Kirsten, which of you comment to that? This brief overview.
Well, I'm going to do this, and I'm going to keep it very brief given the time, just to say that our focus is on ensuring that our systems, culture and leadership are aligned to deliver safe, sustainable and compassionate care. For the past 2 years, the Workforce Sustainability Programme has been focused, as we said earlier, on the reduction of reliance on agency, not just as a financial imperative, but it's about creating stability for our teams and continuity of care for our patients. And that continuity of care, someone who is responsible for the Nurse Staffing Act, although I'm reminded of this constantly now in this role, we know that substantive staff are able to deliver that in a way that is difficult to do with your temporary member of staff. We know that sustainable improvements need to be driven by our people, and we are looking to build the leadership and management capabilities across the organisation, which has been identified as a gap and which Rachel spoke to earlier, and will be absolutely essential for our ability to deliver. We've spoken already about the need to look at our clinical engagement and to we'll be working with our staff in new ways. As a new chair of the board, I've been struck by the very good programme of Leaders That Listen out and about. Listening to our staff, I was with our infection prevention and control nurses yesterday at UHB. We're hoping to revamp the way we should do our board development, which will give us an opportunity to bring more of our staff into the board, to be able to give our board colleagues, independent members especially, greater access to our staff, hearing from them, and to look to already, as patient stories are used within the board, but to make sure that those are robust and that we really look to make sure we can assure ourselves about floor to board reporting and using that, using that as drivers to shape improvements, quality initiatives. So those are some of the things that struck me initially in coming to the board, that there is more opportunity to do that kind of engagement with our staff.
Okay, that sounds positive. Thank you for that. I would like to talk about culture. So over the course of the last year, the board itself has commissioned a number of reviews, both external and internal. And there's been a consistent theme amongst many of those reviews, which suggested there are issues with medical and organisational culture. So I'd like to hear from the board. I'm sure everyone will be able to tell me that that is something which the board wants to address. So I want to hear specific actions that the board is either taking or planning on taking in relation to that. And really an answer to the question, how can, in the context of the theatre review, let's just take one review, how can the board not have known about what's going on, and what confidence you have that this isn't happening in other parts of the organisation?
Okay, with the specifics around the theatre report, I'm going to ask Paul, and then the wider piece of cultural work, I'll ask Rachel. Thank you.
Yes, thank you, Cabinet Secretary. And I know we've spoken about this before previously, but I mean, we did know there was an issue, which is why we commissioned the internal review. We weren't quite sure of the scale of the issue, but we clearly knew there was an issue, which is why we instigated the review in the first place. And the issues that came out were from an internal staff survey that we did. So a couple of years ago, 3 years ago, we kicked off some improvement work, and we were testing how far we were getting with that improvement work when we did the internal staff survey. The internal staff survey was really concerning, and clearly we then need to instigate a more comprehensive internal service review of theatres, which we did. So we had known there were issues in theatres. We just hadn't appreciated, I suppose, the scale of the issues until we'd undertaken the service review.
But why do you think that was? Because it's over quite a prolonged period, isn't it?
In terms of,
Well, these are not newly emerging issues. My reading of the theatre review is these are quite well established issues. So why did the board not have an earlier signal of the scale of the issue?
because we started with, so the reason for that is that we provide theatre services in 4 separate locations. And the theatre review is really focused on what we call upper mains theatre. At the time, Landock was where we were developing our surgical hub and wanted to improve our orthopaedics. So that's where we started the improvement work. At that point, there were no real signals, no noise. So we carried on with that improvement work. It's when we moved into doing UHW that actually some of these very long-standing issues really started to bubble up. And the reason they were long-standing, it's become apparent that they're long-standing is because there had been a culture where people weren't prepared to speak up, or they had spoken up, they weren't listened to. We listened and we did something about it. And I think that is the difference. So we as soon as we realised the scale of the problem, we stopped the improvement work, commissioned the review, and now we've got a Theatres Together programme that's acting on the 66 recommendations. Now, some of these have been long-standing that have not been tackled. We are tackling them, Cabinet Secretary. We are addressing them, however uncomfortable it is, and it is uncomfortable at times. We are addressing these long-standing issues, determined to make the improvement. Your other question about could this happen elsewhere? Well, we can never say never, but we are working hard. So cardiology was something where we heard noise, and we again took a similar approach. We've taken approaches in our sterile services unit. We are not shying away from difficult conversations and difficult issues. We want to get to a position where the culture is such that we don't need to do daily service reviews, but we're just, we are working our way through a large complex organisation.
Perhaps we can talk to Rachel to talk about the culture work, but then also about what the plans are. And Natasha can speak to this about how the board, how the committees and how the board itself can use data and have a dashboard that perhaps in the future will give us greater opportunity to be able to spot some of that. So that's a work in progress, and Natasha can speak to that. So actually what will be being presented will be dashboards, which hopefully will give us better information and data to be able to, as you said, address those issues about.
We're not waiting.
Yeah. The work is going on, but there is work in train as well. Rachel.
Yeah, so I think we always had an ambition about putting the patient in the centre of everything we did with high trust, low bureaucracy. So when the Compassionate Leadership Pledge came out from HIW, we actually took that to board and we signed up. So our approach that we wanted to embed, and we said we wanted to have a cultural leadership programme, which is consistent from the whole health board, looking at data, creating insights, and then actioning with actually the team, co-producing, making each area the best it can be. So looking at all of those things, I suppose we were looking at data such as the workforce race equality standards, the respect and resolutions, and I think that will lead on to the quality management system that wasn't in place, that we actually start to triangulate the data, and we call it noise, but it's the data around that, whether it's high, like I say, grievances or datex. And actually the cultural leadership program, when we started that, the first phase is discovery phase, and that's when we heard people telling us, all of their experiences. Now, some of those experiences in the theatres had been dealt with. They were many, many years ago, but people remember those instances. So,
and some of it was also very recent.
Yes,
So
great.
How does the work that you're describing have a bearing on the recent issues which were being raised in the theatres?
This programme had to stop because this is about actually putting organisational development intervention into an area that actually grows that area. And actually, by continuing the cultural leadership programme, we would have made things worse. Organisational development is around leadership, training, development. So we had to then.
So that stopped across the whole organisation.
Well, we'd only done this in theatres at that point, so we hadn't. So we said this was an approach, but we weren't saying do it everywhere. We said right, there's some noise here. We'll need to start that in that area. Yeah.
Nice. Yes, of course. So it's Suzanne and then Natasha, maybe.
So I think you make an interesting observation, James. I think the issue is people didn't speak up. I'll give you an example. So the staff survey work, I find our level of engagement with that very concerning. kind of really committed myself to drive up, replying to the staff survey and then working with colleagues. So I've made an open invitation to the whole organisation to come to workshops, which I facilitate with the support of Rachel and her colleagues. And we have conversations about what it's like to be a member of our team. How does it feel? How does it make you feel? And how can we adjust? Because my feeling is we can't change the culture of our organisation. I cannot do it alone. We have to recognise everybody's got to play a role to play. And some of the behaviours have been let to go on for a long time. But I sat next to a member of staff from theatres and I asked her, why didn't you speak to us? We're sat next to each other now. And she said, well, we just don't speak up like that. That's not in the way.
Sorry to interrupt. I don't accept the premise. The board is not responsible for the culture of the organisation. Okay. So you just said you couldn't affect it. I don't think that is true. And I would say,
sorry, you can affect culture, but I think in an not on my own. I think we have a leadership responsibility. There's role modelling, there's facilitation, there's conversation. I completely accept that. That is a very important role of the board. But we need engagement, as we've described, across the health board. We need conversations and dialogue, and we need open and transparency between us and trust to facilitate the change that we would all want to see. And I think that hasn't been there. For whatever reason, it hasn't been there, and we've had to really start with building that. And as you can see, we're having challenges doing that today. So that's the journey we're on.
okay, Jackie, then Isabel.
So I suppose the bit I suppose I'm hearing that I'm still not really assured by is I can understand it's good management practice to put heat maps together so you begin to triangulate where you've got areas of issues, and please use patients' complaints in that process as well. But what I'm not hearing is so what are we doing about it? But culture is about how we work around it. Culture is about how we behave to each other. And there's lots of evidence about how we change cultures that I'm not hearing coming out here. There's a lot of yes, we know, we've got this, we've got the other, but I'm not hearing this is where we're going to address the behaviours, to make it feel safe, psychologically safe for our staff to speak up and to actually change the culture. I suppose that's the bit I'm not hearing at the moment.
Let's get Isabel to come in.
And I suppose linked to that, so I was going to reframe it a little bit, saying what I'm not hearing about is what work your clinical leaders are doing to drive professional standards up.
Yeah.
And communicate expectations of clinicians in the organisation, because as you know, your evidence pack highlights increasing rates in healthcare associated infections. You've reported on your bullying and harassment rates. All of these things are related to professional standards within the organisation. So, of course, we would, we see that if you identify an issue, you've commissioned a review and you're implementing the recommendations, but it goes beyond that. And the other thing that would be useful to know is, do you feel now assured? So you said that you both with the theatres and cardiology reviews, you heard noise and commissioned that review. Is there any noise now? Are there things that you are concerned about, or do you feel now assured that the actions that you're taking in place are being effective in driving those professional standards up?
I'll come to Richard and Natasha on the professional standards issues. Sorry.
Okay, so just take it because it might be
So, so first of all, you ought to be congratulated for worrying about an area and taking action to take a look. I do worry about, well, one of the things that creates culture is fairness in the way in which you deal with issues. Yeah. I was very concerned reading some of the reports. You've talked about the values of your organisation. Some of the senior medical behaviours seem to me to transgress what I would regard as acceptable professional standards to a significant extent. Has that resulted in action against individuals? And do you feel that if an Agenda for Change staff member have behaved in the way that some of those senior doctors have behaved, that they would have been dealt with in the same way, because I think that goes to the heart of the fairness issue that is the basis of a good culture.
I'm going to go to our clinical leads first.
Yeah, absolutely. The answer to the question about the clinicians is yes, there is a process. They are undergoing that process as we speak.
We don't need any detail.
And I think you're absolutely right, but the clinical leadership is needed to set the standards, set the tone for what we do. What we've been focused on is making sure that the clinical leaders that we have in place are supported and able to do that. I've spoken to a senior cardiologist since that review came out, and he said to me, you know, it feels like a bit of a band-aid having been ripped off, and actually the cardiologists themselves are working together to improve the outcomes and with the support of the board. And I mean, fundamentally, what they need to see is that we take action where it needs to be, and they will be supported with that. And I think that is our role. We're promoting the right people to lead with those standards. We've got a value-based approach to appointing people to leadership positions, and we are making sure then in the background that we support everything they do. And then in terms of making other departments and whether it's happening there, we are actively, as we said, scouring. We're taking advantage of the GMC surveys, the resident surveys, looking at our clinical incidents, as you said. And in the past, perhaps, where we were dealing with individuals and their positions, we weren't putting everything together. And I think our approach going forward now is to correlate it all, look for patterns, and to tackle the behaviour where it happens.
Can I just follow up on that question? So, Richard, what would you say are the early warning signals for you?
So for the cardiology review, the earliest,
just generally as an organisation,
the earliest warning one was actually the trainee feedback.
So looking forward, as you look across the organisation today, with the benefit of the reviews that you've undertaken, how would you describe today what the early warning signals for you in other parts of the organisation, so that you would know at that point that you had an issue, if you had?
So at the end of every place, every year, there's a GMC survey of all the trainees. Within that, there's free text for them to fill in to raise any concerns. Any that we get in there, we address directly. So Mike Stevens is our Associate Medical Director for Workforce, and we actually just go and find out from the clinical director and from the individual involved. Sometimes it's hard to follow up on those because they're anonymous reports. But nevertheless, if we see more than one or two stating there are problems with people getting unfair access to training opportunities, if they feel they're not getting their annual leave in the same way or the like, if that feeling is there, then it's up to us to go and investigate and look into that.
Natasha?
Thank you. So I think the Kirkup report with about the bridging about the signals is as a board is something that we are working towards very much so. So really looking at all the different data sources to populate. I think you mentioned about heat map and dashboard, but that is something that we're working on in order to, as an organisation, to really identify different areas that will help us to hone in on certain aspects. We've also got our Shaping Our Future Quality Excellence programme that addresses some of the professional standards aspects around their health-acquired infections, which are all led by clinicians in an SRO perspective. Okay. So there is pieces of work along also with our quality management system that we're working towards and with NHS-P&I as well in terms of delivering that.
Okay. Thank you, Natasha. I was going to ask about reading the signals, so you've preempted my question. Well done. And that dashboard in an integrated manner will be able to give you some early red flags, which means you need to go and look as a board as to what's going on, then how you create the right sort of psychological safety for people to speak up. But my question for Rachel is, in the compassionate culture work that you started, if I were to walk around the service and ask a band 5 or a junior nurse who's working in your service alongside their doctors and other AHP colleagues, what does it feel like to work here? Yeah. What would they say about the culture of their units, of their departments right now? What's your sense of your most junior colleagues? What would they say?
I think if you ask the question, do you know about the Compassionate Leadership Pledge or the Leadership Programme?
Yeah, that's not that. I don't want to know that. I want to know what it feels.
Yeah, I think what we do see is the leadership. When the leadership is good, you feel it, don't you? You see all of the data that was good. So when, we're going out on a walk tomorrow, when we go out to do our walk in, people are quite honest, actually. They do open up, and if they are struggling, or if they feel the culture's not good. I mean, I've been in the organisation 34 years, and people will speak up there, but what we want them to do is raise it the formal way as well as talking. So I think, what will they feel the culture is like? I think, if you ask that question, people like Cardiff and Vale. I'm generalising here now, aren't I? But then we have a quarter of our workforce undertaking the staff survey. So our engagement score slightly went down last year. It was 72%. So I think there's more to do. I don't think we can ever get one culture in any organisation. I think there's multiple cultures, but it's just having the right values and behaviours around that.
Sorry, Mary, just come back on that. So what I see is your turnover numbers,
yes,
right, and the change in that. What I see is your sickness numbers, which are pretty high, which tells me your culture. There's a sense that the culture might be different. You're absolutely right.
Yeah.
The grip on what it feels like to work there isn't quite understood. So I don't think that. I'll hand back to the council. I don't think that has been answered in terms of you completely understanding what it feels like as a junior nurse or doctor to work around your organisation. I think there's more work that needs to be done. Perhaps reading the signals is the start, but then the real tangible stuff that you're going to do as a board to truly understand what it feels like to work around, because these metrics tell a different story. Thank you.
Suzanne and Paul are both chomping at the bit. And we've worked really well together so far, so I don't want to ruin it today by not giving them the opportunity. So I don't know which one of you wants to give first. Paul.
Well, two points if I may. So Sue, look, it's mixed. The answer to your question is it's mixed. Depends, and I wanted to come back to Jacqueline's point about not feeling assured. We have, by doing these reviews and putting some people through a process who've never been through, it's not happened before. A number of doctors going through a process. We are setting the line. We're setting the intent that we are not prepared to put up with these poor behaviour. But it takes time for people to trust that we're actually going to do something. So I think that's where we're at. And I know, Cabinet Secretary, you pushed back on us before about, I've said it's going to take 2 years to change the culture in theatres, because we can do the engagement, we can do some of the technical stuff, we can do some of the change, but for people to actually sit back and believe that we've done something, it's going to take time. So I think we've had some really difficult conversations with some of our teams around the models of care, like gastroenterology, for example, that have been hard, but it's been the right thing to do. So I think our intent, we've drawn a line on a couple of things, and now I think people are waiting to see, do they mean it? Are they going to follow through? Do I feel safe to speak up? We have got more people speaking up than ever spoke up before, which I think is a good thing, but too many of those speaking up safely things are anonymous, and we want people to feel confident to put their names to what they're saying, but that we've got a lot to do. Thank you.
Suzanne, anything further you wanted to add?
No, I mean, the only thing we haven't touched on is accountability, and I think that speaks to your professional standards piece. And I think you're absolutely right. I think there hasn't been strong enough accountability down through all of the clinical lines to the front line. And, that is something that we need to effect that in the right way, of course, but it is important that colleagues, it shouldn't matter who you are. If you are not bare below the elbow, then you are advised that you should be. And if you refuse to be, then we have to have a different kind of conversation. That's good medical practice, and that's how things should happen. We truly believe that, and we need to build the confidence in all of our clinical leaders and teams to have those challenging conversations as well. And I think, those conversations are harder for our colleagues than for us often. So I think that's the piece we haven't spoken to, is the accountability right through those clinical teams. And therefore creating some of that fairness about, it's not just one professional group or another that has to comply with a set of standards or requirements. It's all of us.
I'm just going to ask Jacqueline, then I've got, mindful of time, I've got one block of things I want to ask at the end. Jacqueline.
So I suppose what I'm hearing and feeling, I suppose, is that you are dealing with things as they popped up.
Right.
And what I'd like.
And therefore creating some of that fairness about
I'd like, I don't know where that's coming from. What I suppose, what I would like to see from you, and Suzanne, you've been the chief exec for three years or so now, is actually how you build out into the rest of the organisation, what you have learned from those reviews, so that it's a systematic way that you have absolutely spread your values and behaviours and frameworks through there, that people feel ownership of it, that your freedom to speak up, for want of a better phrase, is clear, and the killer question for me will be, but that there is more to do for me about the culture and the behaviours that actually will eventually affect patient care, if it hasn't already, because actually it's not there. And I suppose that's what I would like to see as you as a board putting together, so we have something that is tangible, that feels like there is a comprehensive way.
Okay, I wanted, probably just to do three things. I have a question about the board's view of how all the things you talked about today tie together if they do. So the question really is it the board's view that, you know, just the financial conversation we had, the professional culture, some elements of performance, obviously not all. Is the board's view these are separate and unrelated changes, or is it the board's view that there are common things which unite those challenges? So I'm interested in hearing a bit about that. And secondly, if there's anything that you would like to tell us that we haven't had a chance to raise today, then there's an opportunity for you to do that now. And I just do want to say, necessarily, the conversation turns on all those things which remain challenges and hasn't focused on all the good work that's happening and all the progress that has been made. So just to say that is absolutely understood. So if there's anything specific that you'd like to raise, then we'd be keen to hear.
So my sense of the board, what I've been able to establish is that people absolutely get the interconnectedness of the issues that we're dealing with and grappling with, and we are trying to move the entire system. And that is evidence, isn't it, by the level 4 escalation across all the domains. We wouldn't be in all the domains if we didn't have this whole organisational push that we need to move forward. So I certainly understand that. I think the execs understand it. I don't know whether Rhian and Steve, who've been on the board a lot longer from me, would disagree with that, but I think there is a collective understanding, and the escalation decision, whilst really hard for my colleagues, and I know it's been really hard, has actually, reinforces, doesn't it, the signal to us as an organisation that we need to move collectively across all the domains, and that we will not serve our patients well unless we do the knitting that Jacqueline talked about earlier within the board. But I don't know if Rhian or Steve would disagree, because this is my early doors view.
I think I'd agree with what you're saying. I think, when we talk about financial recovery and having a look forward about when we can, there are so many bits of Lego, if I can put it that way, that need to be kind of collated and then shaped, the clinical plan and so on, for us to be able to articulate our thoughts in that respect. What I would say though is despite the sort of the escalation level status, I am still very much admiring every member of the board in terms of their resilience in wanting to do better continuously. When we are making difficult or discussing difficult decisions at the board about finances and so on, the commitment to the safety in what we're doing, the quality of care and so on is unwavering. And I think as long as we can hold on to that commitment, I think, we will make progress, and we are making progress. And I think, you've identified yourself, Cabinet Secretary, that progress has been made in so many of the domains that we've been talking about today. That's not to say that there isn't a heck of a lot left to progress, but we are mindful of it as a board, particularly as IMs. We are kept informed, we are aware of it, we're scrutinising, we're challenging, we are aware of what needs doing, and we progress. See?
Yeah, Cabinet Secretary, I've worked for the organisation for a long time, and I've worked in Wales for a long time. And the way I've seen the board take ownership for the recent issues around the theatres report and the cardiology review is something I haven't seen in the health board before. it's been dealt with, things like that have been dealt with at local level. So the transparency is there, the collaborative spirit between the independent members supporting the executive team is there. We are listened to, and we are able to affect some of the things that you've raised. They are huge, and I will be honest with you. I've seen the issues develop around the estate, around clinical engagement has waned, and it's improved over various chief executives, and I've seen many in my time. But Suzanne is absolutely up for listening and being able to communicate with the workforce, the entire workforce, not just the medical work.
Thank you. And then last issues. Well, you will have seen at the back of the paper some of the local issues that we've included. It would be really remiss of me not to say that the estate right the way across, we tend to focus on UHB, but actually there's the estate right the way across the organisation. That is a huge risk to us. And one of my priorities is to understand how we can manage that risk. And that's not to say, that's not to pass over agency. There is stuff that we will need to do and we need to attend to, and then hopefully work in partnership with others to address that.
Great. Diolch yn fawr iawn. Thank you very much. Thank you to you, Kirsty, to them, and all of the colleagues for the time and contributions today. It's been a very useful meeting.
Thank you.
And, thank you very much indeed.